Okay.
Okay, thanks everyone for joining us today. We've been hearing from a bunch of Stanford clinical research coordinators about studies going on. And our last speaker today is Yasmin, and she's talking about a couple of studies related to autonomic dysfunction. So take it away, Yasmin.
Thank you so much. So, hey everybody, I'm Yasmin. I am studying my PhD in bioengineering, specifically focused on developing biomarkers of Parkinson's disease. Just a bit about my background. I did some work with Dr. Helen Bronte Stewart prior to my PhD on motor aspects of Parkinson's, and now I've transitioned to more non-motor GI, gut-brain axis markers of Parkinson's disease, working with Dr. Todd Coleman. Yeah, I'll start my presentation. It's a bit shorter. Didn't want to go too long than before, but hopefully encompasses everything. So typically we think of Parkinson's disease as a movement disorder as it's classified clinically, but I'm here to talk about how Parkinson's disease has a lot of aspects beyond just being a movement disorder, specifically things like GI dysfunction, smell loss, sleep disorders, autonomic dysfunction, cognitive dysfunction, things like that. So definitely a lot of systems here at play. Um, and I'm speaking a lot about kind of peripheral systems to the brain, to the central nervous system. So just to orient a little bit about the system I'm talking about. So there's what is known as like the second brain in your gut called the enteric nervous system. And then we have the central nervous system. And together that's constituting to the gut-brain axis. And these are bidirectionally connected via the vagus nerve, which goes up to the brain and then back down from the enteric to the central nervous system. And people typically think of dopamine as a neurotransmitter involved with Parkinson's, but another one that's very important is acetylcholine. And studies have found that decades prior to dopamine loss, there's actually degeneration of cholinergic neurons starting in the enteric nervous system, eventually spreading up to brainstem regions, and then eventually to the central nervous system manifesting in cognitive symptoms. And additionally, some of these areas, including the vagus nerve and brainstem areas, constitute this autonomic nervous system, two of the peripheral systems I'll be talking about. So as I just mentioned, the autonomic nervous system and enteric nervous system are two peripheral systems that are implicated in Parkinson's disease pretty early on, resulting in symptoms such as gastroparesis and constipation, which is why we kind of wanted to dive deeper into this and study this. And typically in clinic, a lot of times there aren't quantitative measures taken over time of these symptoms. It's typically kind of by word of mouth and qualitative measures, just patients kind of describing it. So we wanted ways that we can actually track this, as it does contribute a lot to quality of life. So that kind of led to the study that I'm going to be talking about first. And this is kind of my PhD study. So I'm interested in developing objective measures to quantitatively characterize these peripheral systems in two settings: the ambulatory setting, so this is outside of the clinic, and then in clinic. So that's one study we have with my PI, Dr. Todd Coleman, and Dr. Kathleen Poston. So just to talk a little bit about the two arms of the study that I'll have patients be doing. So first, talking about ambulatory recording. So this would be the out of clinic portion. So there's two systems I'm going to be putting on people. So the first is a continuous glucose monitor. And this is just showing some data about how it kind of looks over time, measuring blood glucose. So this is just a Dexcom Abbott standard of care device that's now available off the shelf that we can purchase. And we typically see early on as well some insulin dysregulation and resistance in people with Parkinson's disease. So I'm curious in measuring metabolic function over time. Additionally, my PI, Dr. Todd Coleman, has created what is called an EGG, electrogastrogram. Think of like ECG for the heart, but sensors on the stomach. So this actually goes right on top of the skin of the stomach, and using some signal processing and totally non-invasively, we can look at the electrical activity in your stomach before meals, after meals, and we can kind of see how those signals modulate over time. So the first part of the study is I either will have people come to me, or I can go to local patients' homes and put these two devices on them and measure over time. So one thing that's really nice that we can also get talking about autonomic dysfunction is information about the heart. So what's really interesting is by putting a device on your stomach, you can actually get heart information. You can get the ECG basically. So what we can do is we can look at signals from a healthy control as well as somebody with symptoms like gastroparesis and kind of look at how autonomic function varies between meals and sleep and wake. And we can kind of give a score to that and then give further analysis on that. So I won't get into too much of the nitty gritty there, but and then just to kind of show what the stomach looks like and what electrical activity we can see in the stomach. Typically, they have seen that in a healthy control, there's these kind of amplitude modulations in the stomach signal. And this is kind of showing just food going through the stomach. And this is showing kind of the electrical signal going through the stomach. It's a pretty slow signal too. But one thing we're interested in seeing is the typical muscle tone at rest. When stimulated, we see basically these regular contractions, but they're happening faster and larger amplitude. But when inhibited, we actually see slower activity and less muscle tone, which we hypothesize is what might be going on in Parkinson's disease, manifesting in this delayed gastric emptying and constipation. So from this device, we can actually look at this over time, which is really novel and interesting. And this is just showing when it is stimulated in somebody that does not have Parkinson's disease, we hypothesize that that is someone with normal cholinergic function. But in someone with PD, when you see this kind of behavior, that would signify somebody with degeneration of cholinergic neurons. Just a little bit about the symptoms. Yeah. That's why we really care about them. They especially contribute to negative quality of life. So that's the first part. Second part, won't get too technical.
Could you just back up, Yasmin, for a
Yes.
second and say what gastroparesis is? I'm not sure everybody. Constipation, I think everybody knows that, but
Yes.
not gastroparesis.
Sure. So basically, when we eat, our stomachs are kind of emptying the food that we eat through the GI tract. But in people with gastroparesis, they actually see delayed gastric emptying. So for somebody without Parkinson's disease, it might take 4 hours for food to get from esophagus all the way out of the GI tract. But typically, in someone with Parkinson's disease or gastroparesis, they see it take closer to like 6 hours. So it moves very slowly through the GI tract. And this may be for various reasons, but one is that there is basically dysfunctional coordination through your GI tract, which is kind of manifesting in this slower electrical activity that we see in this image.
Okay, thank you.
Yes. And then kind of the second part of the study, why I want to do this in clinic. So the first part is patients will be wearing those two devices at their homes. So what's nice is when patients come to us, we'll instrument them with those two devices and send them home and measure for a day or two so we can get some sleep and wake activity. Or if we go to a patient's house, if they're nearby, we can just have them stay at home and measure for 1 or 2 days. So that's the first part. Second part is the patients will come to us within a 2-week span as the CGM lasts about 10 to 14 days. So we want the CGM to still be functioning on the participant's arm. And then we will have people come in within that 2 weeks after the first part into the clinic. And then the main important part of this study is we are first characterizing these autonomic GI measures. But we also talked about how the vagus nerve contributes to these GI symptoms and this connection between the gut and brain and this degenerated acetylcholine. So one thing that people have never been able to do before is to non-invasively measure the vagus nerve activity. And this degenerated vagus nerve, which is propagating this acetylcholine through the gut-brain axis, is dysfunctional and contributes to GI dysfunction. So we really want to be able to measure that in the clinic, but nobody has thus been able to do that yet. So we were looking through a bunch of literature, talking to doctors. So we actually found that there are different phases of digestion, as we all know. So ingestion is kind of the phase where we eat food, stomach becomes distended, your body senses that there are nutrients, and then you kind of have gastric enzymes digesting your food, and then it processes through your stomach and then intestines and out. But this pre-digestion phase is called the cephalic phase. So basically, when someone is prior to eating food, engaging their senses, such as smell and sight with food, this actually starts 20% of your digestion. And this is a totally vagus nerve process. So we are able to basically make people hungry in layman term and be able to measure their vagus nerve activity. And just like looking at the gut-brain axis system, how that works is somebody basically sees food, gets hungry, their brain kind of processes this and sends downward signals to the stomach and pancreas to start the process of digestion. And from that, we are basically able to measure different systems throughout the body and study the vagus nerve there. And how we're going to do that is we have people come into our clinic and we will instrument them with electroencephalography, EEG, so a high density array on the head. And this shows a lot of electrodes. We'll actually do half of this, so 128 electrodes, as well as that electrogastrogram, that stomach patch. And then we'll also put an electrode on the throat to measure swallow activity. As we know, dysphagia is also implicated in this disease. So from this, we're actually able to then measure holistically activity of the vagus nerve in people with Parkinson's disease as well as healthy controls and see how the vagus nerve activity looks differently between the two groups. So just overview of kind of how the study looks. We'll have patients sit for 15 minutes, get a baseline recording. We'll present whatever food that is. And then we'll do the part where we make them hungry, basically study that cephalic phase. And then we'll have people consume the food and then measure how the stomach activity and brain activity look once they have eaten the food. And then we'll ask some questionnaires, including information about their hunger, craving, satiety, things like that. So that is the second part of the study. And this should take 2.5 hours in the clinic. And that's kind of the full study there. Here's the flyer associated with the study. We actually are not doing the smartwatch anymore in case people see that, but we are, and the blood draw as well. We're not doing that part, but patients will receive compensation for this, 2 visits, as I mentioned, all these types of measurement units. Nothing is invasive, just to reiterate. And main eligibility criteria is diagnosis of idiopathic Parkinson's disease for the participants with Parkinson's, and then healthy controls with no GI dysfunction, no dementia or other neurological disorders, no allergies to skin adhesives, as these are adhesives on the skin that we're putting with some sticky material, basically, to hold it in, and then able to sit in a chair for 15 minutes for that second part. And we're pretty open in eligibility, honestly. And we are, very curious to study how people's signals look in both regimes. So this is the first study. And then I will, yes.
And so the first study has 2 components to it.
Yeah,
The wear the device at home,
exactly.
and then the second one is in the clinic, 2 to 2.5 hours. Is that right?
Exactly.
Okay.
So
All right.
we'll be either sending home or have people take the devices home when we instrument them with the stomach device and the continuous glucose monitor. And then we will instruct people when they can take off the stomach sensor, but the continuous glucose monitor is able to stay on for 10 to 14 days. So while that is on, we will have people come in and then re-instrument them with the stomach sensors as well as EEG on the brain, and then a throat sensor as well on the throat to measure swallowing.
Okay. All right. Great. And for both arms of that study, you're looking for PD or healthy controls without
Exactly.
any gastric issues. Okay.
Exactly. And
Okay.
main exclusion criteria is no dementia or neurological disorders, and again, pretty open to recruitment for this. And no, one thing I need to specify that is not on this is no people with DBS for this study.
Okay. No DBS. All
No
right.
DBS. Yeah.
Okay. Very good.
Awesome. Thank you so much for this. And then transitioning, so I have a little short spiel for the second one. So
Go for it.
the next study we're looking at is characterization of autonomic dysfunction in people with Parkinson's disease in a now fully outpatient and remote setting. So just to define what that really means is we will come to people as they're as local as possible to us, and we will be conducting the study at people's homes. And if a little farther, we can make that work by having people come and then be sent home. But a majority of the recording is going to be done at home for this study. So the motivation for this is, as I mentioned before, I'll just kind of reiterate what I mentioned. A lot of people with Parkinson's disease experience gastroparesis, autonomic dysfunction, GI dysfunction, those kind of I'll be kind of using those interchangeably, but the main takeaway point is that because of basically dysfunction in that enteric nervous system, autonomic dysfunction, people experience things like GI dysfunction, constipation. And we are really interested in characterizing this further. Interestingly enough, people typically are treated just for their motor symptoms in the clinic. And as people know, two main therapies people receive is levodopa, so dopaminergic therapy, as well as deep brain stimulation, the STN and the subthalamic nucleus, showing that here. So as I mentioned before, people experience gastroparesis, and we have noticed in chatting with patients as well as previous literature that gastroparesis in Parkinson's actually affects medication absorption of levodopa and results in this delayed on period in people with Parkinson's disease. So due to having this delayed gastric emptying, this affects absorption of medications that people really need to alleviate their motor symptoms. And that's one part. We have actually also have encountered basically from other people that have seen that levodopa sometimes actually helps their GI function as well. So basically, kind of taking away from that, there hasn't really been solid characterization of like what really happens quantitatively. So we're interested in understanding that a little better, and why in some people it helps, why in some people it hurts the um, absorption, as well as in people with deep brain stimulation in the STN, which is a motor region, we have found that people actually experience improved GI motility. So that was really interesting to us as to kind of understand like why that happens. Um, so we aim in this study to first establish quantitative measures of neuromuscular function in people with Parkinson's disease, as well as healthy controls. And then we want to understand how these therapies that I mentioned that typically alleviate motor symptoms, so levodopa and deep brain stimulation, impact gastric activity and symptom severity. So how we're going to do this is so I kind of cut this a little bit since we heard about the QDG device, but we have the previous system I mentioned, the stomach sensors, the electrogastrogram, as well as the QDG system. So what we are doing in this study is we're going to have people in two states. We're going to have them, and this it's kind of laid out here. So we are studying symptom severity with questionnaires and kind of establishing these quantitative measures. But we will have people come in either on medication or on DBS. So this is people with Parkinson's disease. And AIM-1 involves people. So we have one group we're recruiting on just medication, and then one group we're recruiting on DBS. So two separate recruitment groups. So either group is eligible there. We will either go to patients' homes when they are on one condition, so either on their medication or on DBS, and they will be fasted. And then we will first measure their motor activity with the QDG system, the keyboard system discussed before, and then we will measure their GI activity over time, exactly in the same paradigm I mentioned before with the stomach sensors. We will do that for the first day on therapy, second day off therapy. So what's nice here is that we can kind of understand in people that are on medication, what is their motor activity look like, and what is their non-motor, what does their GI activity look like. In the second day, we'll do the same tasks. They'll do the keyboard task, and then we will measure their stomach activity over time again for the second day. And this is in the two therapy regimes. So we can then see how does therapy and then being off therapy affect both the motor activity and the GI activity. And then we will do the same thing with healthy controls to compare against. Obviously, they will just do one day. Well, sorry, they will do it for the same amount of time, but they will never have a medication or DBS condition. They will just do it as a healthy control to compare against. So we are recruiting both groups. Here's the flyer for that. And these are the two devices I just talked about. So QDG, the keyboard system that was discussed earlier, as well as the stomach sensors. They look a little different here, but same kind of premise. It's sensors on the top of the stomach. And we will collect data at home over 2 days, 1 to 2 days. And for patients that are nearby enough, we will go to them and do this. But we will recruit people that have a diagnosis of Parkinson's disease on stable therapy, as we are interested in looking at data on therapy and off therapy. Typical age of Parkinson's disease, able to willing to withdraw from medication regime, as I mentioned, because we are interested in that off therapy condition, and then no dementia or untreated psychiatric conditions. So, yeah, this is kind of a bit about the second study, and we're really interested in how this is in a remote setting. So, typically, sometimes when people come into the clinic, maybe they see motor symptoms and GI symptoms in one state, but when they go home, it's in a different state. So, we're interested in being able to take data over time to kind of see what these fluctuations as well look like and be able to correlate both the motor and GI function.
Okay, thanks, Yasmin. And I'm just looking at the exclusion criteria. You said no dementia, untreated psychiatric conditions. So people can have depression, but as long as they're taking antidepressants and it's depression is well treated, they're still
Exactly.
eligible, correct?
Exactly. Exactly.
Okay,
Exactly.
because I know depression is, of course, very common in
Oh, yes.
Parkinson's.
Thank you for clarifying that. Yeah, that's
Yeah.
totally good as long as it's, yeah, being treated and on stable medication. That's totally.
Okay, and cannot have diabetes and SIBO you mentioned. I don't know if everybody knows what SIBO is, and it's probably not necessary to go into exactly what it is, but do you somehow screen for SIBO symptoms or
Yeah,
uh,
yeah. And I should clarify this, that's just for a current SIBO, people that with currently having it,
oh,
people that were
correct.
treated for
Okay.
it prior is okay too. So
Okay. All
we
right.
would just need to know that from the medical history. Yeah.
Okay, so treated depression is fine and past SIBO is fine.
Yes.
Okay.
Yes.
Right. And but diabetes is a no and
Yes.
dementia is a no.
Yes. Yes.
Okay. And for this one, can people have had DBS?
Yes, yes, exactly. So
Oh,
we're recruiting two groups. We're recruiting people with solely being treated with medication on a
okay.
stable medication clinical regimen, and then a group that is on DBS. It's okay if you take medication with that, but people that have STN DBS, STN or
Okay.
GPI DBS, I should specify. Um,
Okay. And you don't want people with PD who are not taking meds. Is that right?
yes, we unfortunately, yeah, we will not recruit people that are not on this
Okay.
either of the motor therapies.
No PD without meds. Okay.
Exactly.
All right.
Without meds.
Okay.
Yes. Yeah.
Um, let's see. We still have a few attendees. I don't know if anybody has questions. Oh, the one lady got off. So, okay, and participants receive $40 Amazon gift card. This one seems pretty fast and easy.
Yeah.
Not that the
Yeah.
first one's very hard, but the first one's a little bit longer and
Yeah.
a
Yeah.
little bit more
Yeah.
involved. But this one seems pretty easy.
Yeah. Yeah. In a up to 2 days, you're basically done, and it's a bit quicker than the other one. It's still, I guess, like two main things they're doing, like either changing the medication regime or the other one, but that one involves just like a 2 week duration of just like being involved, whereas this one's just 2 days. Yeah.
2 days, yeah. Okay. All right. And what was at the very first slide it said BioX. What that was yeah, first slide for this study. What does BioX have to do with this study? Is it
So
just
the
all
BioX study is what's funding us for this. So
oh okay.
Stanford BioX is we applied for a grant to do this study at Stanford.
Oh okay.
It's the
Okay.
BioX group, the multidisciplinary study group that funds a lot of studies that are kind of doing multidisciplinary, interdisciplinary research in the bio areas. So very
Okay.
thankful for them to fund this.
Okay. And you mentioned Todd Coleman. He's the PI for both of your studies that you talked about today.
Yes, so I forget if I mentioned this, sorry about that. So first study is joint efforts between Todd Coleman and Kathleen Poston, and then second study is a joint effort between Todd Coleman and Helen Bronte Stewart, as she's an
Oh,
expert in the QDG device and
yeah, I
obviously
saw
treated PD
QDG and
patients
I
and stuff.
wondered if she was
Yeah,
involved. Okay.
yeah, yeah, yeah,
And,
yeah.
and Todd Coleman is a physician at Stanford in what department?
He's actually not a physician. He's a professor in bioengineering and by courtesy electrical engineering.
Oh, okay. All right.
And he has a lot of experience with, yeah, developing these technologies for the GI system, and a lot of signal processing and very high level statistical methods and things like that. So,
Okay.
and he has a very big personal connection to GI dysfunction and stuff. So,
Okay. All right, great. I just wanted to get the lay of the land.
absolutely. Thank you.
Asked G1 what role psychology played in her study. So I guess
No, no,
it's your game to ask you what
absolutely.
role.
No worries. No worries. Thank you.
Okay,
Thank you for the
wonderful.
great
Thanks so much,
questions.
Yasmin. Appreciate
Thank-
it.
Absolutely. Thanks for allowing me to share. And yeah, thank you for your time.
Yeah, thank you. Appreciate it.
Appreciate it.
Bye-bye. Bye.
Bye.